So I think everyone's here, so we'll get started, eh? Okay, a very warm welcome and good evening. My name is Dr. Satkuran Mak. I'm a consultant general and minimally invasive surgery and bariatric surgery here from Ipoh, Perak, Malaysia. It's nice being here today on a very warm Saturday evening here in Malaysia. Before I begin, I would like to express my sincere thanks to Ezisurg for organizing this webinar on bariatric surgery, talking about the updates. It is my pleasure and honor to be here sharing this session. And we have with us eminent speakers who have vast experience will be delivering their talks. Before we move on, let me just briefly introduce our speakers. We have from India, Dr. H.V. Shivaram. He's the head of GI, minimally invasive surgery and bariatric surgery at the Esther CMI Hospital in Bangalore, which is also the hospital organizing chairman for the OSICON 2022. And we also have with us Professor Tejana Vijayaratna, who is a consultant surgeon, professor in surgery in Colombo South Teaching Hospital and University of Sri Vijayanathapura. Next, we have Professor Wei J. Lee, someone who's very seasoned in this arena, doesn't require much introduction. And he is the current promoter of Taiwan Society for Metabolic and Bariatric Surgery, professor of surgery in National Taiwan University. Before we move on to our next speaker, I believe I'd like to invite Professor Wei J. Lee to say a few words regarding the talk as well as introduction of the Taiwan surgeons and speakers. Over to you, Professor. Sorry, Professor, it's a bit muffled. We can't really hear you. Probably some technical issues.
Good evening, Mark. Can you hear me now?
Yes, much better.
Thank you very much for your chair the section. I think we are happy to meet you all. And I think this is the first event of Ezisurg meeting. Ezisurg, I think, is a very new company in Taiwan. They try to build some credit and also the medical research. So we host this meeting, I think, for the first time. So you can see we have a lot of experienced surgeons attending the seminar here. So today, I think the topic is quite interesting and all relate to the new advance in this surgical division. So I think I will thank all the speakers and show my great expression also to attenders. So thank you very much, Professor Mark.
Thank you, Professor Witi. And the last but not least, Dr. Kirubakaran Malapan, who is a consultant general, breast and endocrine and bariatric surgeon from Gleneagles Hospital, Penang, Malaysia. Thank you all for being here. Welcome. And thank you for sharing your expert opinion and shedding light on various issues. Ladies and gentlemen, bariatric surgery have come a long way from the time of its advancement until now. And what better way for us to gather and talk about the advancements and to update ourselves from time to time with updates such as this. I will not keep you much further. So let us move on to our first speaker, who is Dr. H.V. Shivaram, who began his initial education in Mysore Medical University in India. He did his postgraduate study at Bangalore Medical College. He's got vast teaching experience in surgery as well as invasive technique. He received various fellowships from the Association of Indian Surgeons, International College of Surgeons USA, Royal College of Physicians and Surgeons Glasgow, American College of Surgeons. And at present, he is currently the head of Department of Surgery and Allied Specialties of Department of Surgery, Esther CMI Hospital. He's also the Program Director of Bariatric and Metabolic Surgery Center of Excellence. He's a teaching faculty and DNB surgery at Esther CMI Hospital, a teaching faculty for fellows of bariatric surgery and metabolic surgery, as well as a trainer at the Bangalore endoscopic surgery. So I'd like to humbly invite Dr. Shivaram for his talk on bariatric surgery in patients with cirrhosis. Over to you.
Thank you, Mark. Are we able to see my slides?
Yes, clear, Doctor.
Clear. Okay. So thank you very much for that nice introduction. I must thank Ezisurg for this invitation, and I am sure all of you who post-COVID taking much of burden of bariatric surgery and also busy with the surgeries, and we all take this opportunity to learn from each other. I bring greetings from Aster CMI Hospital, Bangalore, which is a 500 beds multi-specialty hospital. And I am sure all of you agree that obesity with cirrhosis is a complex problem. Obesity itself is a complex issue, and when cirrhosis is also added, it becomes much more complex. And this issue is increasing worldwide, and the current prevalence is about 30%. Once there is NASH cirrhosis, most of the obese patients have the NASH cirrhosis, and we see more than 50% of transplant recipients have some form of cirrhosis, and this negatively, the obesity negatively affects the prognosis of cirrhosis, and the weight reduction is also very challenging in cirrhotic patients. How does obesity impact cirrhosis? All of you know that the clinical compensation rate is higher in obese patients. It also increases the chances of portal vein thrombosis, portal hypertension, hepatocellular carcinoma, and also the liver failure. The wait-list mortality in cirrhotic patients with obesity may be higher, and post-operative complications are also much more higher. If we take these cirrhotic patients and treat them their obesity, the benefits are much, much higher. It reduces the risk of liver decompensation, improves the compensated stage to the lesser degree of fibrosis. It improves their chances of liver transplant, and also some of the patients, if they reduce weight, the liver improves and transplantation may be avoided, and the comorbidity improvement reduces the risk of surgery when they go for liver transplant in this category. It also improves the graft recipient weight ratio in the live related liver transplant. Factors to be considered in obesity management for patients with cirrhosis is that the excess visceral fat, which definitely increases the bacterial infections and also sepsis related deaths if they're going for liver transplants. Sarcopenic obesity is another very big negative factor in these patients because of the poor outcome, recurrent HCC, and also perioperative multiple complications. Portal hypertension, as you all know, it worsens the problems in this category. So once we know all these things, so how to manage obesity in cirrhotic patients? We know that all these methods, that is lifestyle alterations, the diet and exercises, it's not easy in cirrhotic patients, and ask them to reduce weight by this method only. For anti-obesity drugs, there are n number of them, and they have many more are coming, but there is limited data on safety and also long-term effect we don't know. Intragastric balloons and endoscopic interventions are a good option in some category of patients, but not for all. The bariatric surgery, on the other way, is quite an effective tool, but we have to very carefully weigh the risks and rewards coming out of it. The bariatric metabolic surgery is most durable, most effective. It improves all the associated comorbidities. The surgical risk is increased compared to those without cirrhosis in these patients. That's why most of these surgeries, if you have to do a bariatric surgery in cirrhotic patients, they are best done in a centers of excellence with team approach, and those patients will have good results. The systematic review and meta-analysis from Dr. Sandeep Agarwal from our country, published in 2021, shows that the bariatric and metabolic surgery is in cirrhotic patients, the liver-related mortality is low, but the overall postoperative complications may be slightly higher compared to non-cirrhotic patients. And also the sleeve gastrectomy showed lower postoperative complications compared to Roux-en-Y gastric bypass. So this is a good study involving all the systematic review and meta-analysis. Coming to the assessment of such patients, we have to assess the liver with all the scoring systems, also the portal hypertension with OGD and the imaging studies and surgical risks and reported complications. We have to carefully weigh in these patients. Now, when the surgeon is involved in these cases, the cirrhosis may strike him as a surprise when he does a laparoscopy for a bariatric surgery. Some of them may go undetected before we put the laparoscope. Or we may be doing a bariatric surgery on a non-cirrhotic patient who is not a candidate for liver transplant. And also some cases are done in non-cirrhotic morbidly obese patients who have to undergo a liver transplant. So such setting, whether the bariatric surgery and later liver transplant, that means first you do bariatric surgery, reduce the weight, and later go for liver transplant, or some simultaneous bariatric surgery and the liver transplant in decompensated patients. And in some cases, if after liver transplant, the obesity persists, later they may have to undergo bariatric surgery. So let us see some of these situations. So when it comes as a surprise during bariatric surgery, what to do? This is many people will have problems, whether any true cut biopsy is required, whether to go ahead with the bariatric surgery or abandon the surgery, or if you have to do a bariatric surgery, which is the best procedure. Because of various imaging modalities now available, true cut liver biopsy has not been very popular at this point of time, but many people, if the liver appears okay and their experience and the center is fine, they may go ahead with the bariatric surgery than abandoning at that stage. So which is the optimal method of bariatric surgery in these cirrhotic patients? By the literature, we know that, and also the experience, that the most people nowadays prefer the sleeve gastrectomy than the bypass or the other malabsorptive procedures. Adjustable gastric band is not popular, and most of the people are not doing these days. The RYGB problem is that it is some amount of malabsorption and the nutritional deficiencies. It may worsen the liver dysfunction post-surgery, and also the access to the stomach and biliary tract is not possible post-RYGB. In that, the sleeve gastrectomy scores better because it preserves the endoscopic access to the stomach and biliary tree, less malabsorptive, technically less challenging, and well tolerated either in all settings, whether you do pre-transplant, during transplant, or after transplant also. Some of the problems we may encounter is the bleeding risk in gastric varices and portal hypertension patients, and sometimes portomesenteric thrombosis. If you see the published literature, it is the sleeve gastrectomy which has least complications and no mortality. All other procedures have some complications, and the BPD and all have high mortality also. Bariatric surgery, if you see the median post-surgical follow, 8.7 years, it has stood good test of time. And just a minute. Yeah, okay. Bariatric surgery in patients with compensated cirrhosis can lead to sustained weight loss and stable hepatic function in the long-term follow-up also. So that way, it is definitely very advantageous. If you see the matched control study, cirrhosis group had higher and more severe complications, we already discussed. So when we come to the transplant setting, a patient who has the compensated or decompensated cirrhosis, he has obesity, but he requires a liver transplant. He has to cross this obesity barrier. Because of the donor liver recipient mismatch, difficult to find a donor in such cases. Complications are higher, high morbidity and mortality, and the decreased graft survival. So obesity has to be managed before or during the liver transplant in these patients. If you see the survival after liver transplant, according to the MELD and BMI, the BMI higher, and even if it is the same MELD, that the mortality rate is much higher. So it is the survival chances and the liver complications, everything improves if the BMI is less than 25 or under control, and then do the surgery. So optimal timing of bariatric surgery in these cases, we have to consider what is the liver stage, whether it is compensated or decompensated. If it is compensated cirrhosis, best is to do sleeve gastrectomy first and reduce the weight and later do the liver transplant. So there are enough number of series which have shown good results. In the decompensated liver disease, probably we have to do sleeve gastrectomy with the liver transplant in the simultaneous setting. Or if there are limitations, we can do it after the liver transplant also. After the liver function improves, patient has much better in the liver side, then also we can consider the sleeve gastrectomy, but that's a difficult approach. There are multiple small case series of sleeve gastrectomy after liver transplant, but they have shown good results. So we have the three settings, like in the hernia and obesity management, pre-transplant, which has its own pros and cons, but most of the time it is a good choice if there is a liver is not gone for the decompensation. Simultaneous, the bariatric surgery with the liver transplant. Advantage is it's the single surgery, recovery is same, less risk of perioperative complications related to portal hypertension because patient has a new liver. But it is the problems are potential staple line complications because patients will be on immunosuppressants, potential perioperative issue of two surgeries, malabsorption of drugs, etc., and also the immunosuppression, dosing with the weight loss. There are so many issues we have to consider when you do a simultaneous surgery. Post-transplant, this you have a more stable patient without portal hypertension and good liver function. The problem is technically it's more difficult, challenging, increased risk of infection due to immunosuppression and adhesions, all the problems will be there. Steroids can interfere with the healing also. So these are the things which a multidisciplinary team should sit and decide and take a proper call which is the optimal timing to do. Patients transplanted after laparoscopic sleeve gastrectomy, which is the first setting, you will see that excellent results. Mean pre-transplant BMI comes to 31.4. And if you see the post-transplant weight loss also, this is the black is the pre-bariatric weight and the pre-transplant weight is red one, and the post-transplant also, they have sustained good loss of weight. Sleeve gastrectomy scores over all other procedures in all the settings, and it has consistently shown to be of a better than all other procedure. So friends, if you ask me an algorithm for the bariatric surgery in the cirrhotic patients, our weight goal should be weight loss approximately 10% or more than that. Specialized nutrition, management and activity protocol for gradual weight loss while maintaining muscle mass. This should be the aim, and if we can achieve that, this should be continued in all these patients. If the weight loss goal is not achieved, and if the patient has compensated cirrhosis, we have to measure the portal vein pressure and also do the cross-section imaging to rule out the portal hypertension. And if there is no portal hypertension, we have to assess for the sarcopenia. If there is sarcopenia, better to continue the specialized nutrition program, exercise program, lifestyle changes. And if the sarcopenia is not there or it is corrected, then we have to assess and manage the comorbidities and any risk for alcohol abuse, and then take them for the laparoscopic sleeve gastrectomy in bariatric program with appropriate resources. That means it's a good high volume center. And after the laparoscopic sleeve gastrectomy also, they should continue the persistence of the nutritional program, exercise program, and alcohol withdrawal and care of this patient should continue. But if the patient has a decompensated cirrhosis, they are the candidates for liver transplant or not, we have to assess. If the candidate is not for the liver transplant, then we have to again continue their exercise program and the specialized nutrition program. If they are for the transplant, we should consider bariatric surgery along with or following the liver transplant. So this is the algorithm which is published in the Clinical Gastroenterology and Hepatology in 2021, and this appears appropriate in all settings. So friends, obesity with liver cirrhosis is a double trouble. Conservative measures are the first choice. We should not embark on surgery without adequate preparation of the patient. Bariatric surgery is a good option with long-term weight loss, and complications rates may be higher, but we can mitigate this with proper preparation. Sleeve gastrectomy appears favorable in all settings of the cirrhosis, whether pre-transplant, during transplant, or post-transplant also. These are the surgeries which are better done with centers of excellence, with active bariatric and transplant programs with multidisciplinary approach. Thank you very much for the patient hearing. Thank you.
Thank you, Dr. Sivaram. Okay, I think we will leave all the questions to the end of the session. Before I move on to the next speaker, just some housekeeping announcement. I would recommend suggest participants to place your questions in the chat box, and we will take them and at the end of the session. So moving on to our second speaker is Professor Tejana Kamil Wijaratna. He's a consultant surgeon and a full merit professor in surgery with over 20 years of clinical experience. He's a member and office bearer of several professional organizations. a member of the Court of Examiners for the Royal College of Surgeons, London. He formed the Sri Lankan Society of Metabolic and Bariatric Surgery, who is affiliated and recognized by IFSO. He's represented Sri Lanka at the IFSO Asia Pacific chapter, established total laparoscopic bariatric and metabolic surgery in Sri Lanka, both in the government as well as the private hospitals. So it's my pleasure and an honor to invite Dr. Tejana, who will be talking to us about mini gastric bypass in South Asian patients. Over to you, Dr. Teja.
Thank you very much for that kind introduction. And of course, compared to giants like Shivaram, we are little ants in this field of bariatric surgery. But it's indeed an honor to be a part of this symposium and to tell us what the small or the kind of new. It's pretty new and kind of in infancy of the bariatric program in Sri Lanka overall. So what we can say about the outcomes of our own patients. So I just decided, because of the limited time, to talk about a little controversial issue, but we should give some kind of idea or a matter to debate in a forum like this. I mean, is the mini gastric bypass. Mini gastric bypass has been a controversial operation. Very recently, only the ASMBS has given permission to perform this operation in USA, and in some European countries still it's not allowed. But for some reason or the other, it has become fairly popular in Asia, and I, being a surgeon who performs this operation as one of my pet operations, so I'd like to share my experience on Sri Lankan patients, the outcomes, and of course, mostly talking about the metabolic outcomes of this operation. So we'll talk about the short and medium-term metabolic outcomes in a cohort of Sri Lankan patients after mini gastric bypass. Right. So how do we do it? So basically, I like do the total laparoscopic approach, of course. Our gastric tubes are generally 40 French. I do over 36 French bougie to get a loose 40 French gastric tube, and we do take it as long as possible. And our bypasses, generally is about 125 to 175, depending on the BMI and the kind of metabolic conditions of the patient. Although the standard Rutledge's kind of mini gastric bypass, they talk about 250 centimeter, or about 50% of bypassing of the small bowel. We never go to these levels, and the highest we ever go is about 200 centimeters. That is, of course, in the category of BMI more than 60. So just for the trainees as to how we do it, yes, so this is the typical appearance of a Sri Lankan patient. We are all very metabolically unhealthy, and I'll come to that. And in the standard manner, we make a window in the to get into the lesser sac, and yes, and we divide over the bougie using the staplers right to the top end, and then make a perforation in the gastric tube and measure the bowel and bring it up, and anastomose. We try to achieve about a 3.5 centimeter anastomosis, and the anterior layer is always laparoscopically hand sutured. So this is how a standard mini gastric bypass would look like in our hands. So just to go to a patient that we did recently, a 130 kilogram, a 40-year-old guy. This is a standard picture that we see in Sri Lanka most of the time. And this guy, I've been following him up for just 5 months. And you can see his weight reduction is just average or kind of, standard for just 5 months. But let's just look at the metabolic benefits that this patient has got just for 5 months. You see, I told him he's 40 years. He was only 130 kilos when he came to us. At 35 years, he was diagnosed as having diabetes. Very rapidly, the treatment has to be escalated into multiple drugs. on several drugs for hypertension, hypercholesterolemic, and grade 2 fatty liver. At the age of 36 years, he has had to undergo angioplasty because he developed a myocardial infarction, and he's on CPAP already when he came. So just 5 months later, with only a 36 kilogram weight loss, he's not on treatment for diabetes, and his CPAP was removed. Clinically, his obstructive sleep apnea has completely resolved, and also on one drug for hypertension and hypercholesterolemia, the lipid profile has also markedly improved. So the metabolic benefit that this patient has got from mini gastric bypass, it is definitely way beyond the amount of weight loss that he has achieved. But the same operation, of course, we do in this kind of people, the super obese. Of course, we do have them. And this guy at 238 kilos with BMI way over 60, I think 70, was metabolically healthy. He was he didn't have any illnesses as such. And he has, at 18 months, he has nicely managed to come down to a very acceptable weight with the same kind of mini gastric bypass. So it works in both directions. So we have published our data. Unfortunately, it's our kind of my unit, which does a multitude of multiple types of bariatric operations, and the only other unit in the country has so far done about less than 80 sleeve gastrectomies only. So it's the data on these patients that we have to analyze to see what happens in the Sri Lankan population. So so we have been publishing this data, and what is unique about the Sri Lankan population? So when we analyze about 300 patients over the last 10 years, our average BMI is about 45, so which is very high for most South Asian or the Asian bariatric series. I think it's one of the highest because our average BMI or the mean BMI is 44.7, is just 45, and mean total fat percentage also very high, about 45%. And about 20% of all the patients who have had bariatric surgery in my unit has had diabetes, hypertension, dyslipidemia. I always say in an average of about 30%. So at present, you see, I also started as a predominantly a sleeve gastrectomy surgeon. But at the moment, at present, about 60% of all bariatric operations that I perform on adults are mini gastric bypasses. So we do about 15% Roux-en-Y gastric bypasses and only about 25% sleeve gastrectomies. So in comparing the sleeve gastrectomies and the mini gastric bypasses, the post-op first year and the second year, we have already published this data. We saw a very good diabetic resolution in both these operations. You see, if the diabetic, the kind of duration of diabetes was less than 10 years, there was 90% resolution, even maintaining at the end of second year in both these operations. If the diabetes was more than 10 years, of course, this dropped down to 83% in both sleeve gastrectomies and MGBs. Hypertension, complete remission about 84%, dyslipidemia 90%, fatty liver, all fatty liver grades reduced by 1 grade per year in both sleeve gastrectomy and MGB patients, and complete OSA remission clinically 100% could be achieved in both these groups. And there was no statistical significant difference between the sleeve gastrectomy patients and the mini gastric bypass patients at post-op up to post-op second year. But comparing the outcomes between these two operations, we have now been analyzing 80 patients in the sleeve gastrectomy side and 80 patients in the MGB side, which have gone up to 4 years. Now, like you see, at 2 years follow-up, there was no statistically significant difference in the weight loss outcomes, reduction of body fat percentages, or resolution comorbidities. But at 4 years, we saw a kind of a fairly good difference in the sleeve gastrectomy and the MGB group, where the diabetic remission which was at 87% and sleeve gastrectomy has dropped to 76% because diabetes has come back in that particular group. This is commonly associated with the weight regain and or weight stabilization or kind of change of eating habits. And the mini gastric bypass group remained almost the same. So which is significant. So so this is that ongoing study. We haven't published this data yet, and so we are in the process of analyzing it. So basically, our preliminary kind of idea about this is that a mini gastric bypass is a better operation with regard to maintain the diabetic resolution. And up to about 4 years now post-surgery compared to sleeve gastrectomy. So at present in a country like Sri Lanka with limited resources for metabolic surgery, mini gastric bypass seems to be a much better option than sleeve gastrectomy, at least for shorter periods like 4 to 5 years. So and this is, I think, Professor Vijay Lee has demonstrated this several times, kind of in similar studies that have been then done in the region, and also Dr. Kula in much larger series as in India. So we are no different to that, but our kind of metabolic outcome seems to be pretty good with regard to mini gastric bypasses, and we haven't had any significant complications in that we couldn't manage in either of these cohorts of patients, and of course no deaths. Thank you very much, ladies and gentlemen, yeah.
Thank you, Professor Teja. I mean, many of us will agree that MGB is gaining popularity, and I'm sure we'll have a good discussion with regards to this at the end of the session. So thanks again, Prof. Teja. Okay, let's move on to our next speaker, someone who is very popular in this arena, who requires very little introduction, but then again, we have the honor to introduce him. He's a Professor Vijay Lee. Received his early education in the National University of Taiwan. He's had many publications and many trainees under him, and his past medical affiliations include the past president of Taiwan Association of Endoscopic Surgery, past president of Asia Pacific Metabolic and Bariatric Society, past president of the Taiwan Society for Metabolic and Bariatric Surgery, also the past president for the IFSO Asia Pacific chapter, and who is currently the Asia Pacific Diabetes Surgery Study Group. So it's my pleasure to invite you, Prof, to be speaking on strategies in remission of failed sleeve gastrectomy. Over to you, Prof. Prof, I think you're muted.
Okay. Sorry, Mark. Can you hear me now?
Yeah, we can hear you now.
Great. Thank you, Mark. 这个好像另外有个 online 哦，你要关掉，不然会有 echo。For your nice introduction, yes, as you know, there's also an offline meeting here in Taiwan. So before my talk, I would like to speak some words of Mandarin to welcome them. 大家好哦，我想医师不是很有经验，所以很抱歉，我们今天应该是一个 meeting， 然后待会可能8点以后他们会代表再来欢迎大家。今天很高兴，那个我的老师哈，对，特别有出席。那个满强军医师也有来出席哈，很多早前还有徐光汉、陈志燕，那个不是我们外科医师的内科大他也来哈，这些还有各个好友哈。那我想这个是医师第一天的活动，那请大家享用。那在这个疫情期间能够有这种会议，应该是不容易的，以后应该会越来越好。好，那 So I will start my talk today. Today I'm going to talk about different strategy in revision of failed sleeve gastrectomy. Yes, I'm very glad to see my old friend Sejana. We suppose should have the IFSO ABC in Sri Lanka this year, but unfortunately we can't make it. But we hope we can come back to Sri Lanka someday. Yes, and I'm very glad to hear about OAGB is more than sleep and with a good result also in Sri Lanka and in South Africa. So today my talk is sleep. Of course, we all know sleep is the current most commonly bariatric surgery in the world is around less than 60%, but in some countries it's more than 90%. So sleep is not a leading, there's no question. But we know sleep only have a similar way result as to a room-wide pituitary bypass surgery. So more than 10% of the sleep surgery require revision now. So that is why sleep now is revision is a hot topic. So how many patients need to re-sleep or revision surgery? You can see this recent report from France. You can see in the national registration, revision surgery is around 5% in 5 years and more than 10% in 12 years. It's quite similar to ASMD and also in Taiwan as well. So we can expect 10 to 20% of the sleep patients require revision later in their life. So I'm going to talk about the cause of revision and the treatment strategy for weight regain, and the next is strategy for reflux. The cause of revision, we probably all know weight regain is the most important reason or insufficient weight loss immediately after the surgery. And the second is related to life quality, especially reflux. So, and some patients also have constipation problem. So the main two reasons is GERD and weight regain. So it's like quite simple. But when we make a table 2 by 2 is we have a 4 situation. So in 4 situations, we probably need different strategy to do this. But actually, in the real world, we need to consider more, that including whether the patient has metabolic disorder come back, or patient have some anatomic defect, especially in the initial periods. Many and satisfied sleep was performed in many areas. So this is with an anatomical defect, with those without anatomic, to make a great difference when we consider a revision surgery. So we can talk about the treatment strategy for weight regain. And first, of course, when we measure regain weight of the patient, we need to think about the lifestyle of the patient, or should we change the lifestyle by consulting dietitian? And now the good news is there is more and more medicine, especially semaglutide. This is the most popular medication worldwide. And I think the company make a lot of money nowadays. And these drugs have a good result. So we can expect a 10% weight loss. We have to do a little study to look at the post-surgery patient with weight regain comparing to the primary treatment obesity patient. Actually, in the 3 months, we can see there's similar result. And for 10 years, it's came up to 10% of the weight loss. So when we measure a weight regain after surgery, I think we still can use the medication with good results. Then the next is now coming is a novel treatment. They use the endoscope treatment. We can use this endosuture to close the lumen, reduction the volume. But that's all in experimental treatment now. And surgery, I think, is our priority, I think, because we are all metabolic surgery. So when we consider the surgical treatment for weight regain, we need to understand the mechanism of bariatric surgery. Remember, the most important mechanism for bariatric surgery is restriction. You need to have a restriction effect. This consists of 75% of the mechanism of weight loss. So if you cannot achieve a restriction effect, the revision surgery will not have a good result. So we need to consider whether we need to trim the pouch or we put a band on it. Another is the intestine management, including the BB prolong, and this can consist only 25% of the mechanism. So most of the effect is related to anti-metabolic disorder effect. But when we extend the BB we need to remember the common channel. We need to have enough common channel. So when we consider a patient with sleep, we need to revision. We need to think some detailed technique. The first is whether we need to deal with a diaphragm hernia, that is sliding hernia. We all know sleep has a higher percentage of introthoracic migration. So in this patient, we need to dissect the hiatus, close it, and must complete reduction of the introthoracic migration of the test tube. Then is whether we need to push a mesh or not. We now have a good biological mesh. We can use more freely on this revision surgery. So this is a point we need to consider. The second is the gastric tube. As I mentioned, we need to find back the restriction of sleep. So whether we need to trim the tube or whether the tube has stenosis, we all need to understand before surgery, or it's due to kinking or twist. All this depends on the detailed preoperative study. Then the third is consider when we perform a bypass procedure, we need to look at the gastroenterostomy. We need to consider the size and the location. Do we need a more restriction on size, or we need a wide anastomosis, and the location of the anastomosis we also need to consider. And the third is the BB lead length. Should we use a standard or elongate? And when we use elongated, we need to watch our CC. The previous talk by the journal, you can see, I think because in Sri Lanka, maybe the patient don't eat much protein, so he was pretty conservative to use a shorter BB lead to prevent the malnutrition problem. But if in other countries, patients have diabetes, maybe we will consider to use a longer BB lead. Then the last is the most important thing is crude stomach. If you use a sleeve to do a bypass procedure, you will leave a small remnant stomach. Do we need to resect it or not? It's really a controversial. So in some area with high risk of gastric cancer, maybe it's a wise decision to resect the remnant stomach. I think in most of the surgery, we still keep the remnant stomach because we don't want to resect too much things. And do we need to put truncal? I think this is an important technical issue we need to consider. Sometimes when the introthoracic migration is very severe, you want to a complete reduction, you need to do this procedure. In another situation, if the patient is a smoker with a history of bleeding or something, maybe to combine a truncal is a better decision for this kind of patient, because you can decrease the incidence of marginal ulcer after bypass procedure. So in this, we can see a patient is obese and have the good reflux and also have some anatomical defects. Maybe rural gastric bypass is a better choice. So in this case, you can see the gastric tube is totally kinking and twist over 180 degrees. So patient have severe GERD after surgery and also have some weight regain. So before surgery, he had a 44.4 BMI, and before revision, you can see a BMI regain to 29.8, that's around 30, and with some medical problem. So in this situation, you can see the tube is not ideal and also have severe introthoracic migration. So the procedure is need to reduction the gastric tube bed and dissection the hiatus clear. Then we can do a standard room-wide gastric bypass. We make a hole on this culture side. Then as usual, we can cut the porch. Then after cutting the porch, we can have a good exposure of the posterior hiatus. So that is a trick. Sometimes you need to cut the gastric tube. You see, because there's more gastric tube, then we dissect the whole hiatus. Then we open the posterior wall. We prefer to do a anastomosis on posterior wall because it's more physiological to drainage. And first, we will do a loop anastomosis, most of the surgeon doing. I think we can skip this one early. Then we do the enteral anastomosis. As usual, we use a 60 wide stable line to make the enteral anastomosis. Close it. Then we cut the efferent loop, convert this loop anastomosis into a loop microtrain bypass. And close the mesentery. It's a must when you do a loop microtrain bypass. And finally, we close the hiatus. In this case, we don't use the mesh because this is in the old time. We don't have biologic mesh yet. So now maybe you can consider use this scalpel instead of the other energy device. I think this is acceptable. But as mentioned, in sleep converted room microtrain bypass, we need to have a different strategy for obese and non-obese patients. So in this recent published study, you can see if the patient is less BMI 25 before surgery, we use a short BPD in standard room microtrain bypass. So you can see the BMI remain similar. The patient don't reduce more weight after the surgery. That's what we want. But in patient with more than BMI 25 obese, we will do a standard BPD in room microtrain bypass. So you can see the patient still lose some weight after surgery, but not much because for room microtrain bypass, the weight loss effect is only similar to sleep in a many randomized trial. So when we use the room microtrain bypass for sleep revision, we need to expect not too much weight loss after the revision. So you can see in this situation, if the patient is obese without reflux, we would prefer more to do an OAGB or now the SASI procedure instead of room microtrain bypass. And this is one patient we convert to OAGB because this patient don't have a reflux problem, he only have a weight loss problem. And you can see the previous sleep gastrectomy is not a standard sleep. I believe a very wide gastric pouch and don't touch the fundus. So in this situation, when we deal about a weight regain, we need to resection the gastric tube. So after lysis or adhesion and expose the hiatus, and in the endoscope finding left side, you can see the gastric tube is very wide. Yes. So now, after dissection, we can cut the gastric tube. Oh, sorry. Okay. So you can see we already trimmed cut the gastric tube, and this gastric tube is longer than room. Why? Because we are doing one osmosis gastric bypass, and we trim the proximal gastric pouch and plication the stable line all the way down. So after a nice gastric tube create, then we can perform the one osmosis bypass. And the anastomosis is put on the lower part, and we keep the efferent loop on posterior wall, and efferent loop we will attach to the proximal gastric tube to maintain a smooth passage of the tube into distal part. So this is the case. The finish again, nowadays maybe another energy device can complete the surgery. So this is our data to show the revision surgery for failure treated procedure, including VBG, bend, and some practitioner. So in this situation, if you convert to OAGB, you have a better weight loss comparing to lower ligation bypass. So this is what we prefer now. Then the last topic we are talking about is the reflux problem. So patients have severe reflux after sleep. So the most important thing probably is use medication. I think everybody will use EPI to control the symptom. If medical is not satisfactory, we can use nowadays have many endoscopic treatment. You can use strata to fibrosis the EC junction or create a mucosa flap to treat the reflux. So this is other option. But for a surgeon, of course, we need to think about the surgical treatment. So if the patient has already good weight loss, then we will usually consider non-bypass treatment. However, non-bypass treatment has limited efficacy. In this kind of patient, you can see there's a big hiatal hernia and severe reflux. When we correct the hiatal hernia and fix the gastric tube, and you can see the patient mean BMI is 34. Before revision is 25. It's a good weight loss enough. So we try to repair hiatus, not to do it bypass, and the patient can maintain good BMI after surgery. And at the initial, we can see the quality of life also improved around 50%. But as time going on, you can see there's a recurrence of the symptom. So in the long term, you use the non-bypass procedure to treat the reflux after sleep is quite limited. So we are now doing less this kind of procedure. So now more favor is to use dual ligation bypass to treat the reflux. So if the patient is not obese and with severe GERD and anatomic defects, then we will consider the dual ligation bypass. If the patient don't have anatomic defect, we still can create a long gastric tube. We will consider OAGB. But remember, in 10% of the patient, when you even convert to a lower ligation bypass, the patient still will have a reflux symptom. And the paper report, most of the patient is have a previous either bending procedure or VBG procedure, as this case showing. The long-term, the bending procedure will keep the narrowing of this part. Even we lysis all adhesion to a bypass procedure below. You can see there's still a niche for a long time. And this kind of niche will make the patient have still persistence in that. So in this kind of surgery, we need to do a bypass over this fibrous area. That means a very high level of dual ligation bypass. So this is a point I want to mention. For other new procedures, I think, yes, now we can consider a SASI procedure. This procedure is, I think, it's especially for those with sleep with weight regain and sleep have no big problem. And you don't want to resect the remnant stomach. You also want to avoid the risk of gastric cancer because we cannot do a stop on this small remnant stomach. So use the SASI is a reasonable choice. So the procedure is the same. You need to dissection the hiatus and from anterior and also posterior. You can see the hiatus is also quite big in this patient. And in this patient, we use biologic mesh to close the hiatus. Because now we have a quite good biological mesh. So after close this hiatus, we count the small bowel. So in SASI, our principle is to bypass 60% of the small bowel and 40% of the common channel. In original, they recommend 2.5 meters or 3 meters for common channel. I think if not a good suggestion because the patient has different lengths of string bar. So probably use a percentage is the better choice. And we created anastomosis over anterior wall. We use a technique exactly as the one anastomosis by part we use. A longitudinal anastomosis tackling the efferent loop high and make the footprint direct go into the efferent loop. And up to now, the result is quite similar to OAGB. The only benefit of this procedure is you have a two channel and you preserve the possibility to do endoscope through the duodenum. And this patient already lose a lot of weight, so we can see there's a defect in the message. So we can close it. The important is we check the anastomosis back to entrance to fix the wound. Okay. So again, this is the business time. You can use this. So I make a conclusion to yes, because we did the lab. Yeah, the dinner we need to copy. Sorry. Okay, the conclusion is revision speed is a current hard point. And pre-operative detailed history examination and consulting of the patient are essential because we need to know the patient's concern, patient's goal. That's very important. And for every patient, as a customer, surgery is indeed needed. We need to consider the patient's complaint, patient's goal, and anatomical defect, and evidence medicine we now have, because we always change our policy according to the update evidence medicine in order to maximize the therapeutic abilities. Thank you very much. Yeah, thank you.
Thank you, Prof. Thank you for that enlightening topic on revision. All right. I would like to also extend the session to the offline meeting in Taiwan. If you guys have any questions, please do put them in the box. We are more than welcome to take part in the discussion. Right, we are now down to the last speaker. He is none other than Dr. Kirubakaran Malapan, who is a consultant general, breast and endocrine and bariatric surgeon in Gleneagles Hospital, Penang. Dr. Kiru is a general and a surgeon. He obtained his MBBS degree from Mahe, Manipal in 1999, and subsequently underwent his master's degree in the Science University of Malaysia. And he then went on to do his subspecialty training in bariatric and metabolic surgery in Taiwan. He has served in various hospitals in Ministry of Health of Malaysia, and he's received multiple awards. And he's also contributed a lot to the academics and published several scientific publications. Okay, and he's also actively involved in training Malaysian surgeons, and also a good friend of mine whom I've had the opportunity to work with for some time. So I'd like to pass over the floor to Dr. Kiru to talk about ICG in bariatric surgery. Dr. Kiru?
Hello, thank you very much, Mark, for the very kind introduction. Can you hear me loud and clear?
Yep, clear. Slides also is good.
Okay, thank you. So this is my disclosure. I'm actually a general surgeon, consultant general surgeon with a specialty in bariatric and endocrine surgery based in Penang, Malaysia. And this is the hospital where I work in. And I must say that I'm not an expert in ICG, but I have an experience in using it in parathyroid surgeries for the near-infrared spectrum identification of parathyroids, for sentinel lymph node biopsy for breast surgery, in adrenalectomy, and now using it in bariatric surgery. And of course, all of us have some experience in using it in laparoscopic cholecystectomy. Based on what the previous speakers have all shared with their expertise in bariatric surgery, we know that the number of cases around the world is increasing. We know that the primary surgical techniques are all, exponentially going up, and as Prof. Lee has said as well, the revisional surgeries as well are increasing as well. And I think partly why the popularity is going up is because of the mortality rate as well as the complications in bariatric surgery is actually coming down. And if you see, most of the papers will say that the risk in bariatric surgery is almost equivalent to an appendicectomy, a cholecystectomy, or a hysterectomy, ranging from about 0.3 to about 2%. But however, a complication is a complication, and it's a nightmare for any surgeon. And the dreaded complication in any bariatric surgery, of course, is the leak. And that ranges from anywhere between 0 to about 5%. And of course, when you have a complication, you don't only face the patient, you face the family. There's a lot of problems with the cost that is escalating and so on. So there was a paper actually that was published by Berger et al. That showed that the cost is at least $30,000 cheaper from a primary surgery, which costs about 13,000. And with a complication, it can go up to about 2 weeks a longer hospital stay, as well as a cost that goes up to even $43,000. If you look at the complications, the leaks that is associated in any bariatric surgery is multifactorial. It could be ischemic component, it could be a mechanical component because of the narrowing of the sleeve tube, stenosis at the end, incisura narrowing, or inflammatory because of some infection going on, some collection and so on. But we know that the best way to prevent the leak is, of course, prevention. So, of course, a standardized technique, good training in a high volume center and so on probably reduces the incidence, especially in your learning curve. But however, you might still get a leak somewhere around your 500 case, your 1000 case and so on. And most of the time, it's due to a technique that has changed variability at a time. And of course, something that we can't control, which is poor vascularity. And poor vascularity will lead to poor tissue perfusion. And of course, because of the healing process, some damage there, staple line disruption, and you end up with a leak. If you look at the ASMBS position statement on leaks, intraoperative leak tests, especially by insufflation with air, dye, methylene blue, endoscopy, is all described with about 73% used in sleeves and about 92% in bypass cases. But however, intraoperative leak prevention strategies, which include the oversewing of the staple line reinforcement with buttressing materials, tissue sealants, fibrin, and glue, have not been found to reduce the incidence of leak per se. And the mandated use of any of this equipment is not stated in the guidelines as well. And this is similar for even the upper GI contrast studies and other procedures as well. Now, when you use methylene blue, of course, you can see the staining of the tissues around the area. And of course, when you repeat the test again, you're not sure whether the leak is actually still there or you repaired it when you've primarily sutured the leak. And of course, the cost goes up when you're doing a leak test routinely for every single case. But defensively, some surgeons choose to do it as well because you can document down for medical legal reasons that a leak test has been done and it doesn't show any leak. How valid it is in the court of law, well, that depends as well. And the fluorescence imaging technique to demonstrate a leak at sites of poor perfusion is still an experimental, this one is not in any guidelines at the moment, and maybe that's the why it's not being widely used by most centers. Now, when we talk about a fluorescent technique, principally I use ICG, so I will talk about the indocyanine green method, which is or material, which is actually sterile, anionic, water soluble, and it's relatively hydrophobic molecule, which was approved for clinical use in by the FDA way back in 1959. So it's very widely used in by ophthalmology. It was actually developed in 1940s during World War II and was actually used in by Kodak at the time. Now, the intravenous injection of ICG is rapidly bound to plasma proteins, especially the lipoproteins, with minimal seepage into the interstitium. It's rapidly extracted into the liver, which without any modification, and is excreted in the bile in the unconjugated form about 8 minutes after the injection. So when it's injected outside the vessels, it can reach the lymph node within a time frame of about 15 minutes. And that's why it's quite popularly used in sentinel lymph node biopsies as well. The standard dose for administration in most CPGs is about 0.1 to 0.5 milligram per ml per kilo, and has generally not much side effects. It becomes fluorescent because of the excitation of the laser beam or near infrared light at about 820 nanometers and at longer wavelengths as well. And it can be detected by specialized scopes and cameras. So to date, the use of ICG is still in clinical and experimental applications. You can use it for ICG fluorescence guided angiography for perfusion control, sentinel lymph node mapping as well, or intraoperative tumor identifications. Now, widespread use of ICG as surgical guidance as a form of mapping is still not approved by the FDA. It's still an off-label use. the one vial of an ICG, which comes to about 25 milligram powder, we reconstitute with about 10 mils of water, can cost to about 460 ringgit Malaysia, which is equivalent to about 100 over US dollars. So the costs can be quite affordable, but again, is it routinely needed for all cases? So the application of ICG in bariatric surgery has been shown to be used prominently for identification of blood supply at the GE junction to preserve the critical branches that supply that area where most of the leaks happen. It can identify areas of ischemia when we transact using a stapler. It evaluates the suture line before you proceed with the either doing a gastrotomy or an enterotomy and doing your bypass procedures. Intraoperative leak test with the ICG mixed with saline is another option where you can, instead of using methylene blue which stains the tissues, you can use ICG because it's repeatable after that. I'll show you in the video. And ICG can guide the dissection in revision cases. So if you have or you're embarking in revisional surgery and you don't have much experience, then you can use this form of a technology as a guide. And it's useful in diagnosis to verify bowel perfusion, especially in patients who have had an internal herniation, to know how much of bowel you're going to spare or you're going to resect, because at that time when you're repairing, probably the blood supply is still not perfusing very well yet to the naked eye, but in ICG you can see it better. So the questions that I would like to ask if I'm going to develop or go forward in this technique is, can I use ICG as a guide for perfusion preserving tissue mapping in my surgeries? Can I use ICG to decrease the risk of leak overall, especially in intraoperative staple line ischemia or any misfire? Can I use the ICG to decrease my risk of complications? If your complications are already at that level X, can you reduce it even further? And do we need a leak test after every sleeve gastrectomy or a bypass, or is it only reserved for revisional surgeries? So here, I'd like to just show a video of an after a bypass. This is a patient, BMI about 59. We've done about 30 cc gastric pouch, and the anastomosis has just been done. And now we are checking the perfusion. You can see the flow is going very well to the alimentary limb on this side. And again, the reason why you're seeing only on this side there, you can see the gastric pouch lighting up. It's because of the situation of the camera should be very close to the area that you're visualizing. So this is the JJ anastomosis. It's about 5 centimeters away from the the tissue that has been perfused with the ICG, and you can see that it's taking up very well. You can see that there's relatively no ischemic area around the area, and this gives you a bit of a security as well. So we go up to the gastric pouch. Again, you have a look properly. So I'll be talking about intraluminal demonstration of ICG as well after this. So, okay, right. So now, question number 1, can ICG be used in perfusion preserving as a landmark in a surgical procedure? So this paper was addressed by Camilla et al. And it was to identify the variable blood supply pattern in the stomach and the upper GE junction. So you can see here, 86 patients before a sleeve gastrectomy were given 1 mils of ICG, and using near infrared lighting, fluorescence, they could identify the blood supply, and the sleeve was done preserving the intact blood supply to the GE junction and the gastric tube. And later, another 3 mils of ICG was given after the sleeve was created. Now, in all patients, no complications, no adverse events were seen. And you can see here, intraoperative ICG fluorescence angiography allowed the demonstration of where the blood supply came from. So whether the supply came from the right side, from the left gastric, from the right gastric, or from the right side accessory, that is from the hepatogastric ligament, from the accessory gastric or the accessory hepatic arteries, or it's coming from the left side, which is from the phrenic vessels. So this can give you an idea of where your vascularity is coming from. And I think this idea of this study actually came from a paper from Saber et al., which showed using CT, they can actually map the gastric wall perfusion. And this showed that what was one of the landmark areas, which showed that the mean perfusion index at the angle of His was the one that is mostly reduced and at a risk of any ischemia as well as any leak, potential leak. So the use of this fluorescence angiography, as you can see here, the incidence of a right-sided dominant blood supply from the left gastric is only 20%. From a right-sided accessory, from either the accessory artery in the gastrohepatic ligament, is about 36%. So combined, the right side provides about 56% of the blood supply. Another major group is the left-sided accessory, which comes from tributaries from the left inferior phrenic artery. And this supplies the right-sided supply at about 34%. And you have about 10% which supplies from both sides, from the right and the left. So how does this actually help? So if you are doing a dissection of the hiatus, and you actually go through a pars flaccida technique, and you actually divide the blood vessels that are supplying through the gastrohepatic ligament, then you know very well that the blood supply that's coming from the right side of the, from the lesser curvature, it may be compromised. So that's why when we reduce or when we divide the short gastric vessels, we rely totally on the blood supply from the right side when we're doing a sleeve gastrectomy. So if to avoid unnecessary injury to these vessels during this procedure, probably this is one technique which we can use to identify where the blood supply actually comes from. And this paper actually shows that exploring this technique, perfusion preserving dissection can check the adequacy of the perfusion of your sleeve gastrectomy. Next question. Can an ICG decrease the risk of leak in a intraoperative ischemia in a bypass or revisional cases? Well, to address that, we have a paper by Helmut and colleagues published in SORT. They reviewed 50 consecutive patients who underwent either a primary or a revisional Roux-en-Y gastric bypass, sleeve gastric, or a duodenal switch procedure. And here, again, they used 7.5 milligrams of ICG was injected intravenously, followed by a 10 cc saline bolus. Now, for the bypass group, the initial ICG bolus allowed the evaluation of the Roux limb and the gastric pouch. The second bolus allowed evaluation of the GJ as well as the JJ component. Now, for the sleeve group, a single bolus allowed evaluation of the entire vertical sleeve group. And similarly, for the duodenal switch, an initial bolus evaluated the transected duodenal stump, and a second bolus assessed the duodenal ileostomy area. So the results of this study showed that 3 in 50 cases had decreased or absent ICG blood flow, which resulted in resection of the portion of the Roux limb as a modification intraoperatively during that time. So decreased but adequate perfusion was also seen in the duodenal stump in most of the most of the duodenal stumps that was evaluated, but there were no leakages there. Okay, so even if the perfusion was reduced, the duodenal stumps in the duodenal switch was still quite well perfused, and they didn't elect to redo the stump. Okay, so in all cases of these 50 cases that were studied later, there were no leakages and no post-operative complications. So their conclusion was that the ICG blood flow was good in assessing the anastomosis and staple line in bariatric procedures, especially in bypass as well as in duodenal switch cases. So how about using ICG in intraluminally? Okay, because we are used to probably using insufflation of air, methylene blue. And the problem with methylene blue, again, it stains the tissue, so you can't see it very well. Air, the problem is you need to insufflate quite a large number of, a large amount of water and see the bubbling that is, seen during the test itself. So maybe quite cumbersome. So here we have ICG that can be used intraluminally. So we use about 5 mils of ICG diluted. So you take 25 milligrams dilute with 10 cc of saline, or I'm sorry, water, and then you dilute it in 100 mils of water, and probably use about 100 mils and insufflate into the gastric bougie. Okay, so when you're using that amount, of course, we don't use too much of pressure. You have your assistant actually to holding the alimentary limb over here, and you can see nicely distending. I think by 20-30 cc itself, you start feeling seeing the distension at the gastric pouch and into the alimentary limb. And you can use a little bit of pressure just to see. And again, the point here is not to increase too much of pressure that it causes dehiscence of your anastomosis itself. So you can see the perfusion is quite good. There is no leak. So if you can see here, appreciate a leak if there is a collection of ICG pooling at the dependent area just at the site of the anastomosis. So I go to the next slide. So the question is, do we need intraluminal leak test after every GJ anastomosis? And the answer is by Kelma et al. When they reported the study here. It's a retrospective analysis for patients who underwent bypass and sleeve gastrectomy robotic surgery over 2 periods. One period was when they were using gastroscopy with air insufflation, and a second period when they were using predominantly ICG. And their formula of dilution was a bit different. They used 2.5 milligram of ICG in 100 mils of saline, sterile saline, and 100 cc was used to demonstrate the sleeve tube. And you can see a picture here which shows how much of pooling of ICG happens when you have a demonstrable leak. So in their paper, they showed that a true positive was seen in one case, a false positive in another case, whereas with a gastroscopy with insufflation, you had 2 false negatives, giving a negative predictive value of about 98.47%. However, you had no true negatives in the intraluminal ICG group. So their take-home message is that basically you do not have or the 100% negative predictive value in using an ICG with a very high sensitivity of about 100% and a better specificity compared to doing a air insufflation test. Now, the advantage is that, of course, you do not need the cost of having an endoscopist come into theater and for them to, bring in the machine and so on, which adds on to the cost of the surgery itself. Next slide. So do we need intraluminal test after a GJ anastomosis, after a gastric bypass? So we have Monica Hagen's paper here, published in 2019, where they used about 50 mils of blended methylene blue as well as ICG and insufflated via a nasogastric tube put in just above the anastomosis. So the entire anastomosis was inspected for integrity under fluorescence and normal light. Of course, normal light to see whether the methylene blue was leaking, and of course, near infrared to look at the ICG. So 95 patients underwent this procedure over a 1-year period, and you find no patients had a positive leak test with air, neither with the methylene blue. However, ICG's leak was observed in about 4 patients, or 4.4% of these patients. Now, in the paper, they mentioned that there was oozing of ICG, and the surgeons during the primary procedure sutured the defects itself, or sutured the leaks itself. And following that, there was no adverse events, no anastomotic complications, including leaks, strictures at 30 days post-operatively. So the question here is that if you do not see a leak in a methylene blue test, majority of us were using methylene blue before going down with the ICG. And if you didn't have a methylene blue leak test, how many of these ICG leaks would have actually, developed a full-blown leak? So this is where ethical dilemma actually comes about. When you're looking at the ASMBS guidelines, when you do have a leak demonstrable, you have to repair it, okay? So the bias in this study is that if ICG detects a micro leak, which may not, develop into a full-blown leak and so on, then there is a risk that if you do not suture it, you do not repair it, then you are bound to develop problems later on. So this, I think, will need further study to see whether these small leaks do actually make a difference in the larger context of things. Okay. Now, how about ICG use in revisional cases? Well, ICG fluorescence angiography in laparoscopic revisional cases was addressed by A. Bala. They had a very small number of patients, 13 patients, 4 men, 9 women. And of them, as you can see here, 6 patients underwent the sleeve gastrectomy, 3 underwent bypass, whereas 4 patients underwent a redo laparoscopic gastric bypass after a sleeve gastrectomy for various reasons for weight gain. No adverse effects were seen when ICG was given to these patients. Now, what they did was they did an ICG fluoroscopy score, okay, which was scored between 1 to 5, 1 being very poor vascularization that you can see in this image here on the left. And on the right, you see very good perfusion images as well. So this was given a score of 5. Now, scores of 1 and 2 required the patient to undergo a redo. So either a redo by a suture reinforcement or by a redoing the pouch itself, whereas a 3, 4, 5 didn't need any further intervention. So of these 11 patients, we found that 2 patients had to undergo redo. Of them, 1 underwent suture reinforcement, and another 1 patient, they redid the pouch by repairing the elementary limb and reconnecting it again. So their conclusion is that at 5 months follow-up, no leaks occurred in any of the cases after that. So it could help reduce the ischemic leak rate even without a standardization of the procedure. Now, what do I mean by standardization? You can see here they use 3 mL of ICG diluted in 10 cc's of sterile water. So many of the papers say, they have various ways of using this ICG, either 2.5 mL, either by using 5 milligram, 2.5 milligrams, and so on, with various dilutional standards. So we need to have a standardization of this to be able to draw firm conclusions in many, a large number of series of cases as well. So in conclusion, in my opinion, avoiding a complication is always the best way of, doing a good bariatric surgery and having good outcomes. The second best way is, of course, early recognition. And you want to recognize it early, then you need to do this test that you can actually detect whether there's a leak or not. No evidence, however, shows that you can actually reduce the post-operative complications in bariatric surgery. And I think most of our evidence seems to be showing that in revisional cases, because of the challenging nature of those cases, it's more useful in that scenario. So ICG can provide a valuable aid in the intraoperative assessment, real time, of the vascularity that you're seeing and the tissue perfusion. So you have a hands-on chance for you to actually do something if you find the vascularity and the perfusion being very poor. However, it's a novel technique. It's very sensitive, as I showed us now. The cost is variable. It's quick. It doesn't stain the tissue, and it's repeatable. However, more studies are needed to compare between the standard vision versus ICG to investigate the potential as well in routine practice. And we need a large number of series because the leak number is very, very low. So as it is very low, so you need a large number of sample size, maybe large RCT or multi-center studies. So these are the future directions that we can embark. Maybe we need to have an early identification in potential ischemic areas in certain patients, maybe SLE patients or high-risk patients with cardiac disease and so on. Whether the advantage in uncomplicated bariatric surgery, whether there's a role, that needs to be studied as well, or only in revisional surgeries. And of course, we have to balance the effectiveness against the cost effectiveness as well. And I think we need to have a standardization to identify the vessels, the intraluminal leak test, and so on, or even the ICG for the vascularity itself. And when is the optimal timing, and how far is the distance that you need to put the camera to the vessels that you're going to see as well. So with that, I'd like to thank you all for this opportunity, and thank my team that I work with. And for all Hindus, next week is Diwali. Happy Diwali as well. Thank you very much.
Thank you, Dr. Kiru. Great talk. Okay, so once again, thank all the speakers for the excellent talk and time in preparing such a good session. All right, so now let's move on to the discussion point of view. We've got a couple of questions coming in, so let me get the ball rolling. Okay, this is from Dr. Shiva to Dr. Tejana. Okay, do you see any nutritional issues after MGB in Sri Lankan patients?
Yes, very good question. One of the issues that we have persistently seeing is escalation of an existing problem, pre-existing problem. We are a country with a lot of sunlight, but our vitamin D level is dangerously low in most of the obese women, which is a very, very surprising thing. And in fact, it has come to a point where vitamin D fortification we almost blindly do now, but of course we check the levels. So this further reduction of vitamin D levels is one of the issues that we have seen in gastric bypass. Despite adequate supplementation, I mean, sometimes we have had issues with that. Iron deficiency anemia also has come up after 2 years in certain patients. This is despite kind of supplementation. And during COVID, we have seen another problem. That is due to the lack of the availability of, there were issues with the protein supplementation, provision of protein supplements. And there were a few patients who have had some of their counts dropping on the serum protein levels. But apart from that, we haven't seen any major issues with regard to nutrition. Most of the patients do follow the nutritionist advice, and we don't have very major issues. Yeah.
Thank you. Another question to Professor Lee. Do you see constipation in many of your post-sleeve patients?
Oh, yes. I think it's quite strange because we read the literature. It's very less to talk about. But when we doing in clinical, we will gradually realize this problem because some patient will tell us they had a very good result after surgery. They cure their complication, and also in some sleep, the patient will start to complain you they have a severe complication. So we gradually would question the patient before surgery. Do you have complication? If you do have complication, that is not a rare situation in, I think, in Asia. I think in obese women, if you ask them, about 20%, they already had complication. Sometimes try to be before surgery. So if you don't sleep on this patient, you have a problem because the complications become more severe. So that's better to choose like the bypass procedure, especially one osmosis OAGB. There's a very good response to complication. Yes, we even had some revision surgery from sleep to OAGB because patients have severe complication after surgery. So I think this is quite common in here.
Right. Thank you.
Yes.
Thank you, Prof. Right. One question here for Dr. Shivaram. With regards to the nutritional program for these cirrhotic patients, is it a separate program altogether, or is it a specialized program, or do they follow the conventionally available programs? And what are your thoughts with regards to hypoalbuminemia in these cirrhotic patients who we want to take in for surgery?
Yes, this is a very good question. These are cirrhotic patients with obesity. So the normal obesity program weight reduction will not be very useful. They have to be specialized, and also we have to consider their cirrhotic situation, and the specialist nutritionist advice has to be taken to give the appropriate certain proteins which cannot be given, certain to be avoided, and they have to be under the strict nutritional specialist advice so that they will not go into worsening of the cirrhosis or develop other complications. A normal diet program which we advise for the patients which are not cirrhotic may not be very correct in these things, and also we have to keep on assessing these patients. That's true. Yeah.
Okay. Thank you, Dr. Shivaram. And one here for Dr. Tejana. Many of us here practice a staged procedure for those who are super obese. Some of us, we do a sleeve first and then let them lose considerable amount of weight, take them in for a conversion. But now with the gaining popularity of the MGB or the OAGB, what are your thoughts of using this procedure for super obese?
Yes. Actually speaking, sleeve gastrectomy came to place in this particular manner because it was we kind of, it was almost accidental thing. It was a part of the kind of the digital bypasses where people used to do sleeves first and then do the bypass later. But then what happened was, I think the DSDJB, what happened was then a particular number of patients didn't come for the bypass component, and they continue to remain kind of very well maintained with their weight loss. So so in our practice with the, I think what has happened with the mini-gastric bypass is, you see, after the kind of performing the resection of the great, like, you know, division of the greater curve, it's almost like a sleeve gastrectomy, if you agree with me, the initial part of this operation. And the joining of the small bowel happens at a very lower level. and not like in a Roux-en-Y gastric bypass. In a super obese patient, sometimes with a big liver, a lot of fat, getting a bowel loop up into the 20 cc gastric pouch is a massive challenge. But with the mini gastric bypass, it's like if you can do my argument is if you can do a sleeve, you can do MGB. It's like that. It has come to that. So no, practically I have never. I have done super obese. I have a series of patients on that. I have never done a kind of sleeve gastrectomy on a patient that I have planned for mini gastric bypass, except in one super obese patient where there were extensive amount of additions in the abdomen, where pulling the bowel up was a challenge. I mean, there of course we decided to do a sleeve, but apart from that, I think with the current place in MGB, this staged operation for as a sleeve gastrectomy, then reduce weight and then do a bypass is almost obsolete.
How about the other speakers, Professor Lee, Dr. Shiva, Dr. Kiru? You guys feel the same about this?
Yes, I think MGB is an excellent operation for super obese patients because of its easyability, because it need not go to the G junction so much and do an anastomosis or anything. And if you do a correct amount of bypass, it gives excellent results, as Dr. Teja has showed in one of his photos also. It's an excellent procedure for super obese patients.
I agree with that. Yes, my favorite. I think in super obesity, if you do a surgery, then any surgery, the risk is the same because the problem usually is associated with operative care. So to do the procedure is sometimes even difficult than OHGB in super obesity. And if some complication happen after sleep, sometimes it's very difficult in management. So I would rather to straight go to OHGB even in super obesity.
Okay, thank you. We have one question for Professor Lee. With cases of post-sleeve kinking or twisting, what are your thoughts about using stents instead of surgery?
I hate stent because in the old time when the sleep leak, I read the literature, I tried many stent. I thought it myself, I tried to invite some endoscope to do it for me. But later I find stent is a temporary vessel and some is good result, but most of them don't have good result. And the patient suffering because it's foreign body, they will complain you for 1 or 2 weeks for years. So finally, I abandoned the stent. Yes. So if a kinking or twist, I think you can try mechanical clarification maybe. Yes. Stent. I think the cost is the issue because who paid the stent? Usually, if you ask a patient to pay, then they probably complain, and the national insurance they usually don't cover this kind of. So I would rather do a revision surgery to treat this problem after they use us. Then also have migration. They never read it in the literature, but almost every patient migration of the stent. So you have lots of problems to meet this stent. That's my personal experience.
Thank you, Prof.
Participant in here, 还有没有什么要讲的或者讨论的，都欢迎。We have a most senior president, Professor Huang from Lincoln Children's Memorial Hospital. Yes, they want to talk.
Yeah, and thank you for all the speakers. I enjoy all their presentation. I have to ask the first speaker, here one that of the Thailand. That's because in Taiwan many patients with liver cirrhosis and obesity. But not in the class A, but for some patients it's class HRV cirrhosis, have some ascites or moderate ascites, but not indicated for liver transplant in that situation. So in that situation, in the patient with HRV liver cirrhosis, do you agree to do it's a sleep or other procedure for bariatric surgery for the patient with liver cirrhosis with child B. Do you understand?
Yeah, probably Dr. Shiva. Just
Mark,
refresh.
I couldn't hear properly.
Okay, I think what doctor mentioned was in patients with Charles B with ascites. What are your thoughts on performing weight loss surgery on these patients?
So these are the patients we have to consider whether they are going for the liver transplant, or they are basically requires initially the bariatric surgery to reduce the weight. Child's B cirrhosis, if we are taking for surgery, probably sleeve gastrectomy is a good surgery, and then take them up for later for the liver transplant if required. Or with the weight loss itself, the liver may improve in many of these patients, and they may not go for liver transplant also. So child's B cirrhosis with uncompensated liver and mild cirrhosis, they can go for sleeve gastrectomy. And such a situation in our hospital also, we have done one patient, and he has not yet gone for transplant.
Okay, thank you.
Once you lose the patient's weight, their liver function improves quite a lot. That's a lot of improvement.
And there's one here for Dr. Kiru. What are your thoughts on two questions? Sorry. What are your thoughts on using ICG in emergency surgery, such as leaks or perforations? And is there any evidence comparing intraluminal and intravascular ICG?
Yeah. So in emergency, I couldn't find anything, because the number of cases that patients who have centers who are doing ICG as well, there was not much in the literature for me to actually draw upon. So in emergency setting, definitely I think there was none. Personally, I feel that if you're using it in an emergency setting, to look at the vascularity, probably of maybe less example. For example, maybe it's a perforation. So you want to redo the pouch, especially in a marginal ulcer. So probably there's a role there. You probably have a leak that is happening, over a few days or so on, because we are talking about either it's an early leak or a delayed leak, right? So you have to look in that context. And if it's available, then I think it's an adjunct that will probably help you in mapping out the anatomy and for you to do your transaction safely. The second question was for, what was the second question, Mark?
Any difference between intraluminal and intravascular ICG?
Yeah. So there are two ways of using it. Either intravascular, for you to actually map the vascularity itself, and the second thing is using it as a like a leak test. So you can use it. You can use both actually. It's about timing of when you're giving the contrast. So if you're giving intravascular, the half-life is probably within 1.5 to 3 minutes. So it lights up very quickly. If you're diluting it into a normal saline and you're giving it into the intraluminal through the bougie, then you can give it immediately. You can see the contrast actually taking up inside the pouch, and you actually make out and see whether there's seepage of the material through the staple line or through the anastomosis of your hand-sewn suture. So this is the two uses I can use, and both doesn't have to be at the same time. The problem is if you're given intravenous or arterial ICG, looking at it, and you do a leak test, then it might obscure and you probably won't see it very well. But if it leaks out, then you can make it very well. So that's why the false negative value for this is actually, the negative predictive value is a much better result in doing this test for these patients.
How about our other experts? Have your experience in using ICG?
I think it's a very good concept because, as Kiru said, the intragastric and also leak test, ICG leak test. So we have one more leak test to add into air leak test, methylene blue test, and also the ICG leak test. That's a very good concept. We have no experience on that. Congratulations for that. I think should be published or looked into seriously.
I personally don't have any experience in here, but I think in revision surgery, it is a good idea. Yes. But in most of the primary surgery, because now it's quite safe and usually you probably don't need that. Unless only one procedure, I think now surgeon try to do Nissan plus sleep. We had some experience in this. We had a terrible result after this because the blood supply of the Nissan with sleep is jeopardized by doing a sleep. So I think it's a good idea to use IPV to check the blood supply of Nissan on the vacation. They sometimes convert the Nissan sleep to room while or pure sleep because the blood supply is not satisfied. I think this is what I read is a good indication to use ICT. This is my experience.
Excellent discussion there. So I think we have approached coming to the end of the session. Any other thoughts or views from our excellent speakers? If they are not, then I would think we will end today's session. It was indeed great having this opportunity to have this discussion with all of you. I would like to thank Ezisurg once again for coming up with this excellent program. Just before we sign off, can I invite everyone to turn on their cameras so we can just have a group picture before we end? Okay, ready? 1, 2, 3. Okay, thank you once again. Have a great weekend and wishing all Hindus happy Diwali. See you guys soon. Thank you.
Thank you.
Thank you.
Thank you.
Take care. All the best.
Bye. Thank you.
Bye.